But I'm going to talk today about some of the work that I've been doing in New York City with an organization that I founded called Hip Hop Public Health. So I want to start with a story of a child. This was a 5th grade child who, as a result of the work that we do in the community, in the school systems, he was able to save the life of his father, who collapsed in the bathroom and was having a stroke in front of the child. So I thought I would just begin with this.
I wake up to go and use the bathroom to pee, and I find myself next to the bathtub. I feel that little electricity coming down, and everything stopped.
I was worried. I didn't know what to do. Then I remembered what the hip hop stroke told me, and then I did it. If you see someone that has blurry vision and their arm gets weak and they have a really bad headache, call 911.
Daniel, I think because of his knowledge, he knew what the right step to do, call 911. I probably would be more panicky, but they gave me strength from how they behave and how they spoke to the 911 operator. It gives you a second chance in life, because I probably would have lost him.
So this is a child who was part of our hip hop stroke program, and it's really quite remarkable. We have a number of kids across the country that are doing similar things, but this was actually a byproduct of our primary outcome. Our primary outcome was to make kids stroke literate, so that they would transfer that information to their parents, so that their parents would be the ones recognizing stroke. But now we have an army of children across the United States who are doing this. How does this happen? This is not just giving people information. You can't give a child an information and his father collapses in the bathroom, and that child does the FAST test, overrules his mother, calls 911, tells the 911 operator that my father's having a stroke, and gets him. That doesn't happen by just giving knowledge to someone. There's something more that's happening here. And hopefully, as I go through this talk, you'll understand how it's critically important for us to figure out ways to take knowledge and activate it in a way that's culturally relevant, in a way that's engaging, inspiring, and impactful. So why this was really important for Daniel's father was because Daniel's father had what we call a right MCA stroke. And a right MCA stroke, and this is a real image of a right MCA stroke, occurs when there's a blockage of the blood vessel supplying blood to the right hemisphere of the brain, and it can be quite life-threatening, can be really devastating. There can be swelling and herniation, we call it. So you have to move quickly. You have to move really quickly. And if you look at the yellow arrow, you can see where there's the blockage from the blood clot. And this is another picture of the blockage. This is an angiogram that we did on the patient. And then we did what we call a mechanical thrombectomy. And we went in and we removed this, you see the size of this clot from the brain, and we were able to restore blood flow. And the patient went home a couple of days later. This type of response is what we call the Lazarus phenomenon, and it is taken directly from the scene. This is Rembrandt's famous etching of the raising of Lazarus from the dead. And you can see the point of where Jesus is raised from the dead. You can see Mary and Martha just marveling at that resurrection. Literally, when we treat our stroke patients in the emergency room, we do sometimes observe this Lazarus phenomenon where their disability literally evaporates over the next 48 hours and they go home with their families. But time is brain. Every 2 million every minute of an ischemic stroke, you lose about 2 million brain cells. So it's critically important for us to act quickly. If you look at the number needed to treat for one patient to return to independence, rather than a lifetime of disability, it's 4.5 within 1.5 hours of onset. So time is really critical. And if you look at endovascular treatments for functional independence, we need treat 5 for one additional patient to achieve functional independence. But the biggest problem that we see, especially in marginalized communities, especially in communities that have been disenfranchised by the effects of structural racism, is that they just don't come in. They just don't come in. And they don't come in for a bunch of reasons. And so pre-hospital delays in these communities is the greatest barrier to our ability to treat them. Daniel's father was 45 years old. If you look at the regards data, you can see that the disparities in both mortality and incidence increases the younger patients are when you compare black and white patients. It attenuates around age 80, but that's just an artifact of survival. But if you look, by the time you're within the ages of 35, you keep extrapolating that chart, by the time you get to between 35 and 45, that hazard ratio is 4. That's pretty serious. Pretty significant disparity. There are also disparities in treatment rates. There are also disparities in recovery. But I'm going to talk about treatment rates and how we were addressing that in these disenfranchised communities. And so the main reason, and I'm going to cut this short, but the main reason, it's a very busy slide, for low treatment rates is, to simplify all this, is poor stroke recognition and the failure to immediately call 911. That is the main reason. And poor stroke recognition comes from a myriad of factors, and I'll talk about some of them later. And so we know that there are 5 broad social determinants of health, and we know that these social determinants of health are a critical target of our interventions because in the United States, clinical care only impacts 20% of the variability in health outcomes, and social determinants of health affect as much as 50%. And if you look across those domains, some of the things require multi-level interventions, some of the things require structural interventions at multiple levels, including societal, political levels. But there are lower hanging fruits that we can address, and one of them is health literacy. You know, I've always believed that the road to health equity has to pass through health literacy. And, you know, education, we know, is severely affected by structural racism. Just as an example, you know, in the United States, a lot of the public school systems are funded by local taxes. About 50% of their funding comes from local taxes. And if you think about the neighborhoods, and if you think about the property values in certain neighborhoods, and if you think about how these property values were historically decimated by federal policy around redlining, you'll understand how it's very difficult for certain communities to generate sufficient revenue to sufficiently fund their public schools. So those public school systems have been devastated by historical racism. So already there's an educational disadvantage. Already you have challenges with health literacy and all those related behaviors. And so we realize also that, you know, arriving early in the hospital, sometimes it's not the patient himself or herself that makes the decision to act. Sometimes it's those around the patient, the family members, the spouse, the child, who's around the patient that says, you have to go to the hospital. You cannot wait. You have to go to the hospital. And we know from the data that family members' knowledge about stroke is it's a critical component for early hospital arrival following an ischemic stroke. And so we decided we were going to target family members. But we knew from the communities that we serve that it's really difficult to target the highest risk groups, which falls between 35 and 55, because a lot of these individuals in these communities are hard to target. They work 3, 4, 5 jobs per diem. How are you going to, they don't watch TV because they're so exhausted, and when they come home, they might watch a movie. So how do you target this group of people between 35 and 55 who are at very high risk for stroke? How does public health reach these individuals? The older retired individuals are easy to reach because they go to senior citizens' homes, they're in churches. They're much more easy to reach even with these communities. But these high-risk groups, how do we reach them? And so we decided that we were going to reach them through their children. We were going to, and the only reason why we decided that is because I had 2 young kids at the time. My daughter at the time was around 13 and my son was 9, and they would come home and I'd be exhausted because then I was a junior faculty member. I was exhausted from patient care and being on call, and they would say, "Daddy, you have to help me with your homework." And so I had to revise my algebra, brush up on all the stuff that they would make me do with them. And now I'd realize that, oh my God, I'm actually learning stuff as I'm doing homework with them. And so we said, if I can learn through my kids, and I'm incredibly busy, but I have to make time for them, then surely these folks in these communities can also learn through their children. But how do we do that? How do we actually do that? And so we came up with, and we published a framework that we call child-mediated health communication. And the whole premise of that framework is that we could take children, make them literate about stroke in this case, and then empower them with the skills and the behavioral skills to transfer that information successfully to their parents and their grandparents. Remember that about 30% of these children are being raised by their grandparents in these communities. And they're even higher risk for stroke. So they can transfer that information to their parents and their grandparents, and we could measure the effect of that knowledge transfer from the child who we can capture in the school system to the parent and the grandparent. And we felt that this was a viable approach to public health knowledge dissemination. But how do we get children to learn about stroke? It's very distant to them. And how do we do that? Not just to learn about stroke, but how do we get them to learn about it and then take that information to their parents? It seemed like a tall order. And so we put a transdisciplinary group together that included children from the target population. We partnered with our Department of Pediatrics, we partnered with our School of Public Health and the school system, and we partnered with the entertainment industry. When I would walk down from Harlem Hospital, which is on 135th Street in Harlem, all the way down to 125th Street, I used to make that journey because it was really hard to find healthy food. So I'd have to walk, a number of blocks before I could find a healthy food. But one of the things that always happened on that journey during breaks was I would see these young kids on the streets, and they would be rapping songs from beginning to the end, verbatim. And so I was like, well, if they can know all the words to these songs, we can just take the symptoms of stroke and any medical information and put it in the song and create a curriculum that's driven by the music. And so we put together a transdisciplinary team, and we created Stroke Ain't No Joke, which was our hip-hop stroke curriculum. But developing a health literacy intervention for children is not easy, especially one that's empowering. And so we published a model that we created called the multi-sensory, multi-level health education model. It really talks about how you can take an art form, in our case music, take culture or use cultural adaptation frameworks, and take science and work through a transdisciplinary team to create a health literacy intervention, and then look at the efficacy and then the effectiveness in randomized trials. And if proven effective, then disseminate across the socio-ecological levels of behavioral influence. And so our child-mediated health communication model really employs a lot of validated models of behavior change. And it took a while before we actually came with the right framework. A lot of small pilot studies, a lot of health communication studies, really looking at the best approach to actually do this in a way that would lead to the type of results that we needed. So I can't spend too much time on it, but we did publish the paper, so you're happy to look at exactly how we do this. But we use this approach to develop our hip-hop stroke intervention. And our hip-hop stroke intervention is really this, we call it a transmission vector hypothesis, which is child-mediated health communication. It's a simple 3-hour self-administered, or we have a facilitated model. It consists of hip-hop multimedia lesson plans that's tailored to national health education standards as well as New York State standards, because we were operating in New York at the time. And then there are supplemental components of the curriculum that's facilitated. But there were no instruments to actually measure our outcome measure, which at the time was stroke literacy. So we had to develop our own instrument, psychometrically validated, and you can see the alphas are pretty strong across all the 3 major subconstructs of our health literacy tool that we call SLAM, Stroke Literacy Action Measure. But another important thing is the powerful effect of music. You know, music, as we know, has very primal effects on human beings. It can reduce our stress. It can help us learn. It can help us remember and retain things. I mean, how many of you can remember the exact song you were listening to the first time you fell in love? Or how many of you remember, you know, in such vivid detail how music has this incredible effect at bringing out making scenes more vivid, making memories better retained. It helps us learn. Think about the alphabet, A, B, C, D, E, F, G. We learn through music. Think about Star Wars. I'm a big Star Wars fan, and you hear that Darth Vader soundtrack coming, and you know that Darth Vader's coming, and the whole tension in your body just from the music. Or Rocky, if you like Rocky, you know, Rocky running up those stairs. You know, I still listen to Rocky's theme song when I'm running. So music, the point is, music has incredible effects. We use it to help patients speak again. We call it melodic intonation therapy when a stroke patient is aphasic. We use it for our delirious patients with dementia. It calms delirium. We can take off restraints by just using music. So it has incredible effects on the brain. It's bihemispheric. Language, we know, is unihemispheric, usually on the left side. Music is bilateral. It's so powerfully engaged with such effects on the body that we realize that this had to be tested in this area. And so we created our first video, which is called Stroke Ain't No Joke.
Now if he don't sound right, then he's doing the stroke. Sway when he walks, then he's doing the stroke. Slur when he talk, then he's doing the stroke. Call 911, cause it ain't no joke. Now X is for the face, and A is for the arms. X is for the speech, and T is for the time. Time to do what? Call 911. Time to do what? Call 911. X is for the face, and A is for the arms. X is for the speech, and T is for the time. Time to do what? Call 911. And that's the way that the stroke is done. Come on. Everywhere
We also have a Spanish version.
Como ciego, ataque de cerebro. No pierdes tiempo, ataque de cerebro. Rápido, llamas al 911. Era muy fea, hasta los brazos, la lengua se derrama. Ya es tiempo, ¿tiempo de qué? Llama 911. ¿Tiempo de qué? Llama 911. La cara muy fea, hasta los brazos.
So this is what he did. He listened to his kid. The moral of the story is you know.
So it got a little lost in translation, but there's also a video game that we created with hip-hop, and there are other videos that talk about lifestyle behavior change, smoking risk, healthy eating, etc. So the children also get cardiovascular prevention models as well as the stroke action models. And this is the comic book that they get, so it's multimedia comic books, video games, and cartoon videos, all focused around stroke recognition, action, healthy eating, and healthy lifestyle. This is our most recent video, which adds B and E to the fast mnemonic.
B for balance, E for eyes, F for
face it, don't matter what side. A for arm, S for speech, T for time. Call 911. Teach. B for balance, E for eyes, F for face it, no matter what side. A for arm, S for speech, T for time. Call 911. Teach. I'm feeling a little off, feel a little dizzy, I'm feeling a little lost. I'm having trouble when I see the same thing that happened to you could happen to me. Face gets numb, gets weak, doesn't matter what side, start drooping in your cheek. Kinda numb when you use it. Touch your arm, touch your leg, can't move it. Speech when you're using your tongue. Time to call 911. Sometimes we gotta panic and I kinda understand it,
but you gotta call 911. See the moral of it all is you gotta make a call. If you see somebody looking real sick, be fast, be wise. Don't hesitate, you gotta move quick.
Come on, B for balance.
And this is an example of a class. This is what the class looks like. Sorry. And the teachers love it because the kids just have so much fun learning. It's very interactive. They play their video games and they have homework activities. The homework activities, we actually created a composite score for parental sharing. So they're supposed to watch certain cartoons, rap the symptoms to their parents, read the comics with their parents, complete other activities, and then watch the prevention cartoon with their parents. And these are some children, a video of some children talking about the symptoms of stroke and their experience with hip-hop stroke. And so we ran a randomized control trial. We randomized about just over 3,000 children and just over 1,000 parents to the hip-hop stroke intervention or an attentional control. We published the article in Stroke if you want more details. But the bottom line was that we were able to meet all our primary outcome measures. The intervention effect on the children was really striking. Really high self-efficacy for calling 911, really high self-efficacy for describing that event, and this is using the validated instrument that we developed. The parental sharing was really high, stroke preparedness was really high. At the parental level, we had very strong stroke literacy at the parental level, and this is just using a binary, not even a continuous outcome, just a binary outcome. For every 100 parents, 20 had perfect stroke literacy scores. And then within the context of the trial, we had 6 intervention children. That number has since increased to about 32. This was a quasi-experimental study that we did in Harlem, and then we found basically quadrupling of our TPA rates in that community as a result of the intervention. We worked with the state. In New York State, there's a requirement for all stroke centers are certified by the state. And we worked with the state because we realized that one of the requirements was public stroke education in the catchment area of the hospital. But there were no strict guidelines about how that should be done. And so we worked with the state to create new policies requiring hospitals to use evidence-based approaches to educate their local communities. And so we then used a hybrid model, a hybrid effectiveness type 3 model, to design an implementation dissemination project with the Department of Health. And about out of the 120 stroke centers in New York State, 42 are using the hip-hop stroke intervention in their local communities successfully. And so if you look across the socio-ecological model, we know that we were able to make the children more stroke literate. At the interpersonal level, we were able to really transfer that information to their parents. At the organizational level, both stroke centers and local schools we were able to really expand and diffuse the intervention into local school systems as well as hospital systems. At the community level in Harlem, we started seeing a shift in those norms, and calling 911 for those symptoms were now becoming the norm in the community. And at the policy level, we were able to work with the state to actually change their community education policy around stroke. We disseminated the program through specific strategies at educator level, using young people. These are usually college students in our historically black colleges, working with stroke coordinators and working with community health workers, those that are healthcare affiliated, as well as those that was the CBO affiliated. And so we had a very systematic dissemination model. So we've disseminated now to over 20 cities in the US. Some of the cities you can see here. This is our Nashville group of ambassadors. This is one of their classes. We have about 22 ambassadors in Nashville. And then we also have our program has actually been replicated in several countries in different languages. And so just to summarize, the hip-hop public health approach really involves taking art forms like music to increase not just the competitiveness, but also the absorption of health literacy initiatives, especially in this attention-poor community. Kids are inundated with information, and attention is one of the most precious commodities in human society today. Cultural adaptation, we believe, is critical and can increase the level of acceptance and relevance of these initiatives. We always believe in using science to demonstrate the efficacy and effectiveness. You know, as a Columbia professor running around with rappers, I have my reputation at stake. And so I had to make sure that I run very clear, randomized controlled trials to demonstrate this worked, so that people understand that this is not just a passing fad, but this is a real model that can be used across a number of disease domains. And then we published our model, the multi-sensory health education model, that really teaches how this is done. And a lot of groups across the United States have now used that model to build different types of programs targeting many different types of conditions. And again, just to say again that health literacy is really critical. It's a critical destination on the journey to health equity. And we believe that at Hip Hop Public Health that, expanding the role of and aligning educational goals and healthcare goals with these health literacy interventions can help to scale them as we have done in the United States. I have a very big team. I just want to, these are my research staff and some of my co-investigators. These is my data coordinating center. I have partners at NYU. I have partnerships at Sinai in Florida. This is the Hip Hop Public Health team. We also work with the CTSA at Hip Hop Public Health. And I've been so fortunate to have on my board DMC from Run DMC and Dougie Fresh, who I started the organization with, Salt from Salt and Pepper, as well as Chuck D from Public Enemy. And these artists have been critical in really helping to guide the direction of our interventions as well. And I'll stop there. Thank you.
The applause does you credit. Thank you so much for sharing the story of Hip Hop Public Health with us. You really emphasized on the importance of creating new alliances, which is crucial to public health, actually. And I asked all the other speakers about a piece of advice, and I would like to ask you about advice on how to create new alliances. What does it need to ally with education or with the entertainment industry?
That's a great question because it's not easy. That's the first thing I would say. But I think that we're in a special moment now where, the world was so shaken by COVID that people now realize that there is a higher purpose that we all must aspire to. And that higher purpose is making the world a better place. And to make a world a better place, you have to reach across the aisle. You have to reach across sectors. Doctors have to work with teachers, and teachers have to work with politicians, and we have to work with entertainment industry and the film industry, and the commercial sectors have to break down silos, and we all have to work across, specifically around the goal of really improving the life of society. So I've found that today there is more interest and more willingness to partner across the aisle, but it needs to be done really systematically. You have to look at what the shared goals are. We aligned our Hip Hop Stroke program to the national and state health education standards. School system must engage in health education as part of their wellness activities. And that health education needs to be standards-based. And so we took a standards-based approach and we aligned it so that when the teachers ask, how does this matter to me? It's fulfilling their science component as well as their health education component. And so finding these alignments, these unlikely alliances, I think is a critical part of forming these new partnerships.
Thank you. I think we will use the next 2 days to find exactly those alignment of goals, these new coalitions. So thank you again,
Thank you so much.
Jide.
Thank you.